depression and anxiety, an area where sadly we don't know quite as much about from the point of view of therapeutics, but we will discuss. So I'm going to riff right off of where Dr. Wilson left off, which was talking about, first and foremost, before thinking about adding on a psychotropic medication, to look for other diagnoses, both psychiatric, but also importantly medical. And indeed, I won't belabor the point, but it's very clear that you can make psychiatric diagnoses in this population, including even those with autism and intellectual disability, that have validity and prognostic importance, as well as telling you something about likely response to treatment. Now, unfortunately, we know that across the board, individuals with ASD are at increased risk for the whole range of psychopathology or psychiatric problems, including psychosis, including bipolar disorder, as well as the areas that we're going to talk about today. So it is important to screen thoroughly with respect to the behavioral phenotype, if you will, of your individual patient with autism who's presenting with challenging behaviors. The importance of screening and taking a quantitative approach as well as a clinical one is getting to the point to where you can identify a target or a behavior that's most impairing, and also attach a measure to that, which is going to be key not only for diagnosis but for evaluating the impact of whatever treatment you may employ. And then also echoing Dr. Wilson, all too often in the behavioral management of individuals with autism, what we see over time is this adding on phenomenon of one treatment, one medication being added on top of another and another and another. And then when one tries to work backwards and figure out, okay, well, what is treatment X helping with or not, and treatment Y, it becomes extremely complicated. So I think an important guiding principle is, if one is unsure about the impact of a psychotropic that you're looking at, you're much better served to stop that and start over. Okay. So as I said, I'm going to focus on a couple of different treatment targets. Irritability, which is really kind of a concatenation of aggression, self-injurious behavior, tantruming, ADHD, sleep disruption, and depression. So let's jump into irritability. So this is the only behavioral treatment target that we have two US FDA-approved treatments for, risperidone and aripiprazole. In terms of parent surveys and other assessments of individuals with autism, this is a really common severe and challenging behavior. Not to say that it is chronic, but if you look over the lifetime of an individual, as many as half on average will report a significant period of time where these behaviors have been quite problematic, quite impairing, and a focus of treatment. Even within that, likewise, parent data tells us that within the lifetime of an individual with ASD, 15% will have a period of time in which they've experienced severe self-injurious behavior with tissue damage and need for greater structure, impact on quality of life. Now, some have critiqued the concept or the construct of irritability as being kind of a mishmash of a variety of different symptoms. And I can't argue that it's so specific. The way that it's typically measured is with the aberrant behavior checklist, a very common behavioral survey that is used in individuals with intellectual disability and disorders such as autism. It's made up of 15 different items that are rated on their severity and frequency, those being self-injury, aggression, mood, tantruming, and loud dysregulated behavior. One way to maybe think about it is that it probably bears most resemblance to agitated depression, given the features that are commonly associated. While we do have 2 FDA-approved treatments, these are sort of our ace up our sleeves, so to speak. They're very powerful medications. They, as you well know, they come with a variety of serious long-term side effect concerns. But importantly, they work, and they work very well and reliably so. And so this is from one of the original studies that ended up leading to the FDA approval, in which this is from a sample of kids treated from 5 to 17 years of age, and they had to manifest very severe levels of these behaviors folded into irritability. In fact, many of them, in terms of their clinical global impression severity rating, were considered marked or very severe, which is a level of severity that would often get one in a hospital, would get one kicked out of a special education placement, et cetera. And so what you can see is in this 8-week controlled double-blind placebo trial, you see very limited placebo response. On the top line. And risperidone titrated within the first 4 weeks shows a relatively rapid decline in these irritable behaviors that continues across the 8-week period. So by 4 weeks, final dose level was achieved. And what I think is notable and clinically meaningful about this particular graph is that even by 2 weeks prior to reaching final or total daily doses, you'll see significant reduction in these behaviors. So the meaning of that is if you're embarking on initiating risperidone treatment, if you're not seeing fairly significant improvement within the initial 2 to 3 weeks, you may be in a position of needing to think about an alternative. Also important clinically in this study of a sample average age of about 9 years of age, but including a fair number of adolescents up to 17, is that the mean daily dose was 2 milligrams per day. And in consultations that I have with community-referred patients, I often find what I think is overdosing, over-treatment with this medication in the community. So I think it's important to note that even a mean daily dose of 2 milligrams per day can be very powerful in reducing these behaviors. Well, an acute response is great, right? But how durable is it? And what data do we have with regards to what happens if you were to discontinue it? So as part of that same study, those who achieved a good response were invited to continue on for what would be a total length of treatment of six months. And we learned, I think, some important lessons from that open label extension phase. Number one, there was no need to continue to increase dose. The dose stayed almost the same. It only went from 2 to 2.2 milligrams on average across that additional 4 months of treatment. Secondly, the behavioral improvement also was quite stable over time, with little deterioration at all. And then for the first 32 patients who reached the end of that total of 6 months of treatment, they were offered to be entered into this blinded discontinuation phase, in which across three weeks they were randomly and blindly switched to a relatively rapid taper of the risperidone, or continued with same dose treatment. And we see the results of that using survival analysis here, in which the dark purple group continued on the same dose of medication over a period of additional 7 days. And those in orange, the taper begins here and then goes to 0 to just placebo after about 21 days, decreasing by 25% per week. And you can see that within a relatively rapid period of time, between the time of the completion of taper and switch to placebo versus the flattening out of relapse, which was defined as a return of greater than 25% from entry of these irritable behaviors. Fully 62% of those switched to placebo showed relapse. For the group that continued on same dose risperidone, only 12% relapse. So it was a powerful demonstration of the continued benefits of risperidone on the one hand, but equally important to me is the fact that about a third of these kids were able to come off of risperidone, at least for this almost 3-month follow-up period, without deteriorating. So that brings up the whole question of length of treatment. I think these data and others suggest that this medication can continue to be beneficial. But I do want to highlight that there's an emerging literature, mostly coming out of Europe, that is looking more in adults than children of the impact of antipsychotic discontinuation. And those studies thus far look to reach quite similar conclusions, namely that this group of individuals with a mixture of problems, autism, intellectual disability, the combination, are tending to show improvements in both daily functioning, adaptive behavior, and even some behavioral improvements as well. So this is different from maybe 6 months discontinuation, but I do want to highlight that, and I'm guilty of this myself, that if I'm using a medication like this for treating severe irritability, I'm tending to be very gun-shy about proposing to decrease or discontinue the medication. But I think from a safety point of view, we should be asking ourselves this question at least every year, and perhaps even as frequently as every 6 months. Can we make a reduction without losing behavioral control? Can we possibly even discontinue? In other longer-term follow-up studies from individuals, children with autism treated with risperidone, we see similar durability of treatment for the most part, and without the need to advance the dose that significantly. So I've brought up the issue of safety of risperidone, safety of antipsychotics, broadly speaking. And that leads me to what's probably, I think, our most compelling concern, which are the metabolic side effects of these medications for the whole class, not just these two. I do want to bring to your attention somewhat newer data suggesting that we have some tools to possibly help mitigate some of the metabolic side effects with more widespread use of metformin in kids and adults. who have exhibited significant antipsychotic weight gain is shown here, in which metformin was added on to individuals who had shown significant weight gain and who 90% or so met criteria for obesity. And you can see, particularly in terms of BMI decrease, that the metformin was really doing what we'd hoped for, and significantly separating with towards normalization, not necessarily reaching it. And one point about this study, and I can also confess being fooled about this myself as well, is that this benefit of metformin is somewhat delayed. You may really need to pursue treatment and monitoring for as long as 2-3 months before you really begin to see this declining trajectory with respect to BMI and stabilization of weight. So our hope is that use of treatments like metformin, who knows what the future may hold, may enable us to continue where needed safe use of antipsychotics. Aripiprazole, as I mentioned, is the other FDA-approved treatment for this behavioral target in individuals with ASD, and this is one of the few larger-scale head-to-head comparisons. Two main takeaways here. One is that at the end of this 6-month treatment period, the weight gain was almost identical in both groups. Mean daily dose risperidone, 2 milligrams per day. Mean daily dose aripiprazole, 10 milligrams per day. Almost the same in terms of weight gain, although the trajectory or the rapidity of weight gain was much greater in the risperidone group than aripiprazole. And this was blinded treatment throughout this period. And then for the most part, depending on perhaps what camp you ascribe to, the two drugs showed equal efficacy in reducing these behaviors. There were actually some time points where risperidone achieved superior reduction versus aripiprazole, and as you can see at the end of the last couple of observation periods, approaching 6 months, the mean daily irritability scores were lower in the risperidone group. So what else do we have to choose from, though, besides these two very, very powerful treatments? There was a lot of excitement with the publication initially, now 10 years ago, of the possible benefits of N-acetylcysteine. And wouldn't that be great to have a over-the-counter supplement that would be an alternative for this condition? There certainly are going to be some kids who may get significant benefit from NAC. In this study, placebo-controlled response rates of 40% to NAC handily beat placebo. But you will notice, though, that the starting point for irritability was about 10 points or 40% lower than in the risperidone and aripiprazole trials. So you may want to think about NAC in the context of milder irritability, or less severe, less urgent need for control. Now, unfortunately, folks at Cincinnati Children's tried to replicate this study with NAC and could not, but suffice it to say that this is an option. What about other approaches? For the most part, other antipsychotics, both first generation and later, will show benefits on this target. But other interesting agents as diverse as memantine, valproic acid, will also be beneficial, efficacious for some individuals, and may be preferred if one gets to this point. Another non-antipsychotic would be guanfacine, and there's some data even suggesting that stimulant treatment in a particular phenotype where there's both irritability and high levels of ADHD behaviors could benefit irritability as well. So I'm going to switch to a little case here, although noticing the time is slipping away. And so this is a case of an 11-year-old, idiopathic ASD, very bright young boy, referred to me by one of my beloved pediatric neurologists, secondary to continued irritability. He had first been started by the former clinician on citalopram, titrated up to 20 milligrams for what was thought to be a lot of negative mood symptoms. And the response to that was really pretty limited. The neurologist had moved on to add risperidone and had marched up to a total of 4 milligrams per day, a pretty significant dose in an 11-year-old. That had led to significant improvement overall in aggression and irritability, but there was still, mom would still report that it was frequent, perhaps at least 3 times a week, where the boy would become quite physically aggressive, even pushing and hitting mother, as well as younger sibs. And mother had had an organ transplant, and this was, it seemed very precarious. So there was more work to be done. So what I did, without changing anything else, was first to add immediate release guanfacine and to titrate that up ultimately to a dose of 1 milligram morning, half milligram afternoon, and 1 early evening. And this seemed to work pretty well. Aggression rates dropped further. Overall, everyone was happier, as you might imagine, fewer conflicts at home. And this enabled us, over time, to drop the risperidone by half, down to 2 milligrams per day. So we were feeling pretty good at that point, and I think that shows that more than one medication, unfortunately, may be necessary. Let's move on to another common behavioral target, ADHD symptoms and ADHD diagnosis. I fault our developmental psychology colleagues for this, but this comorbidity, this co-occurrence of ADHD and autism was largely ignored until DSM-5 changed the criteria that allowed us to make both diagnoses. And in fact, regardless of what kind of clinical setting you work in, probably a third of individuals you work with who have diagnoses of autism spectrum disorder will also meet criteria for ADHD. It's very impairing disorder in terms of both parent report, parent complaints, but obviously as far as benefits from therapy of all kinds and ability to engage successfully in their social environments. Fortunately, the measurements that we use for neurotypical kids work just fine for capturing these behaviors. So the first question is, what about standard ADHD treatments that work for neurotypical kids? Turns out, indeed, across the board, those are useful and are solid options. Methylphenidate, as shown here, with benefits observed by parents, teachers, and blind clinician raters. The caveat, though, with the stimulants in the treatment of ADHD in this population is that the overall reduction in ADHD symptoms is a little smaller, and if you look at global response, those kids that we all would agree, oh, they got very much better or a lot better, that drops from the neurotypical rate of maybe 70, 75% down to more like 50%. The other piece relating to stimulants and kids with autism spectrum disorders, their heightened sensitivity to the stimulant side effects. In this particular study, 1 out of 5 kids dropped out of the study before they even finished the full titration and crossover trial due to side effects. So that is a definite limitation. Other options, guanfacine extended release, shown in this study, also funded by NIMH, to show clear benefit, placebo not budging very much, guanfacine showing a nice separation by week 4 with an average daily dose of 3 milligrams per day. Dropout rates much lower than with the stimulant, very well tolerated. However, we went to great lengths to also measure cognitive change, hoping for cognitive benefit, but also worried a little bit about the possibility of negative cognitive effects. What did we find? 0 cognitive change. So no gain, like with a stimulant, but no adverse cognitive effects, which is reassuring. So some of the colleagues across the different sites with guanfacine would vote for guanfacine as their first-line treatment. Others would consider a stimulant first. And then there's a third solid option, atomoxetine, or brand name Strattera. And it also has solid evidence base as well. If you actually count up the number of subjects in published controlled trials, it outnumbers that of stimulant trials and guanfacine. This may be underdosed a lot in community practice. Mean daily dose in this largest study was 1.4 milligrams per kilogram per day. And the power of the atomoxetine-only effect comes through in this study in that there were 4 different treatment groups, including atomoxetine and parent behavior management, but the atomoxetine-only group fell right on top of that had the additional parent management. So this is also another good option, I think probably underutilized as well. I'm going to go back quickly to the same case, in fact, that continued to follow, now only on 2 milligrams of risperidone per day, same dose of guanfacine, total of 2.5 a day. Child moved on to middle school, not in a special day class because he's very bright and very academically talented, more than 1 or 2 commands or requests. So his daily routine requires mom or dad to basically, tell him one thing at a time: get dressed, brush your teeth, etc. And struggling at school despite his aptitude, and especially having homework still. That is a routine point of conflict during the day. It's hard for him to complete work, to engage for very long, doesn't seem to focus, and it actually sets off a lot of temper outbursts. But aggression and irritability still improved. So on top of risperidone and guanfacine, we added extended release dextromethylphenidate up to 20 milligrams per day, much improved. Large decrease, almost 50% in ADHD symptoms. But more importantly than that, we were able to slash the risperidone even further to just 1 milligram per day. And we were all quite happy about that. So polypharmacy, although we would like to avoid that, still very common and necessary in order to manage the complex behavioral challenges that we see. And now quickly to sleep and sleep-wake cycle disturbances. No question, as you all know, very, very common in this group, as well as individuals with intellectual disabilities across the lifespan. And this comes through in a variety of surveys. We see here just how commonplace these reported sleep problems are across a wide range of groups: Angelman syndrome, idiopathic autism, intellectual disability by itself, Prader-Willi syndrome. This is a part of the maldevelopment, if you will, of these NDDs as a group. Now, within idiopathic autism, it has been noted, and there's some evidence to support the belief that there's a subgroup of folks who have reduction in melatonin synthesis. And indeed, as you know, melatonin is frequently sought out as a potential treatment for these sleep-wake cycle differences, particularly problems with sleep initiation. And this is from a recent study looking at extended release melatonin, and the results are quite dramatic, quite powerful, that this looks like an excellent option for many. But more importantly than that, to their credit, they did a 2-year follow-up, and they showed both maintenance of benefit in the majority and no negative growth or other concerns about that have been raised about changes in the timing of pubertal development. So melatonin, if it works, can be an excellent initial option. Now, going beyond that, I know in the clinic where Dr. Wilson and I worked together for a long time, across the 6 or 7 attendings, each one had their favorite second line, third line, fourth line treatment, and we love to argue about it endlessly every week in clinic. And we even created algorithms, but we never really came to a consensus, did we? No. So sorry, Rajuta. But amongst those other options that I think all have some potential benefit and individual efficacy, clonidine alpha agonist, of course, mirtazapine is one that often comes up. There is a branded low-dose doxepin, the old tricyclic, very sedating, lots of antihistaminic properties that has come on the market. Trazodone, gabapentin, quetiapine, and then the newer orexin antagonist. And I would highlight this excellent paper by our former colleagues Besterman and Jesty in the European Journal of Child and Adolescent Psychiatry that really does a nice review of potential sleep medications in this population and talk about their experience with orexin antagonists, something that I think also we may ignore too often. It could be quite useful, especially for those kids who have seemingly the most dysregulated circadian patterns in sleep and wakefulness. So I'm going to skip that and finish up. Depression and anxiety, as I mentioned before, is far too understudied. And it was only until recently that we began to identify this as a very common comorbid neuropsychiatric condition in individuals with autism. Perhaps a quarter to a third meet criteria. The importance of identifying anxiety and depression is that, of course, it frequently is the driver for what may be the dominating feature of the clinical picture, including aggression, irritability, self-injury. So it bears important consideration in evaluating those that present to us. Besides depression and anxiety, suicidal ideation and attempts have been found to be increased in this population. And I think most recently there was a paper from a Scandinavian registry in Sweden showing or demonstrating quite powerfully that this is a real risk amongst individuals with autism compared to neurotypical comparison groups. What do we have in terms of treatment? Unfortunately, our knowledge base is quite paper thin here. There's been some studies that have attempted to look at what you might think of first, SSRIs, of course. We know from those studies that benefits on anxiety are just really not that powerful, and rates of SSRI disinhibition, activation, even behaviors looking almost like hypomania are quite increased. In one study with citalopram, the mean daily dose of 18 milligrams per day, fully 25% of the kids receiving citalopram developed at least one symptom of this either severe insomnia or agitation, etc. Despite that, though, I think from a safety standpoint, low-dose SSRIs do represent sort of the general consensus as first line. So to sum up then, we do have solid evidence in regard to treatment of a number of these really, really common behavioral targets. Beyond evidence, there are a number of options, and we hope that those will come under even more rigorous study in the future to help guide us. But that said, of course, the heterogeneity of autism spectrum disorder challenges any kind of simple, one-step or two-step approach. So one often does need to be thinking about, okay, well, what are some of the other options available? As I mentioned from the outset, we should do our best to, despite my case history, of trying to avoid the temptation to add on rather than take away, and I do want to stress that. And then lastly, of course, as we're moving towards measurement-based care, we do need to, this is a particularly important area where we need to try our best to quantify the impact of the treatments that we do utilize. So thanks very much. Look forward to your questions later.
We're going to go ahead